Hello, and welcome to today's Lunch and Learn presentation called Menopause, Let's Chat. I'm Amy Schemenauer, the Senior Director of Marketing at North Kansas City Hospital. Thank you for joining us. Menopause affects every woman at some point in her life, but no two women have the same experience. Some women struggle with common symptoms such as hot flashes, night sweats, and mood swings. Other women have only mild symptoms, and some women don't have any symptoms. The obstetricians and gynecologists at Meritus Health Pavilion for Women and Meritus Health Obstetrics and Gynecology are extremely knowledgeable about the signs and symptoms of menopause and how to treat them. I'm excited to introduce you to Dr. Jackie Werner, an obstetrician and gynecologist with Meritus Health Pavilion for Women. She is also the medical director of Club W, our health and wellness community for women. Dr. Werner is here to talk about the changes many women experience during this time in their lives. She will also offer advice for managing symptoms so you can continue living life to the fullest. Dr. Werner graduated from the University of Missouri-Columbia School of Medicine. She completed her residency at the University of Kansas School of Medicine. Please join me in welcoming Dr. Werner.
Thank you so much, Amy. That was a kind introduction. Well, thank you everyone on the other end for joining me today over lunch. This is an exciting topic that I'm super passionate about. So I'm excited to get more information out there about this, as well as answer any questions you may have. Given the unusual format of today's chat, given that it's virtual, what we'll do is we'll answer any questions you have at the end. So feel free to write them down and we can answer them after. So I know what you're thinking. Who is this young woman? She hasn't been through menopause, and you're not wrong. But I am very passionate about my job. When I got into the career of OBGYN, I'm excited about taking care of women who change our world. I'm excited when I work with teenagers and help them through their first contraception. I'm excited when we're working with women to get pregnant. I'm excited to help people through their labor and delivery, and I'm excited to help people through menopause. So while it's true, I haven't been through it myself, I sure can help you through it, and I'm excited about doing that. So let's start with what is menopause? And this is a really important question because so many people come to me and wonder if they're in menopause, and that does change a lot of what we can offer you and what we can do to manage your symptoms. And it's really actually a very simple answer. It's just 1 year without periods. And it's not a lab value alone. Some people will come and say their labs showed that they were in menopause, and it's true that labs can be helpful, but it's certainly not a lab value alone. We compare your labs with what your periods are like. Labs cannot accurately predict when you will start or go into menopause. And what I mean by that is if a woman comes into me and she's 47 and having irregular periods and she says, my goodness, when can I predict that this will be over? It's actually a little more helpful and accurate to know when your mom went through menopause rather than to collect labs, because they're inaccurate at predicting when you'll have your last period. It can't be determined accurately if you're on hormonal medicines, and typically the hormonal medicines that women are on are things like birth control, or if you have health problems that could affect your periods. Common ones include hypothyroidism or other autoimmune diseases. Labs can be helpful in those situations. When is menopause? On average, it's age 51 to 52, and that's when it's spontaneous. It can occur earlier than that from medical intervention. For example, if you've had both ovaries removed. When we do a hysterectomy, that includes typically the uterus, cervix, and tubes, not necessarily the ovaries. So women who go through hysterectomies don't necessarily go through menopause. Menopause can also occur from chemotherapy or radiation, and that can occur early from, again, something we've treated you for in the past. It can occur at any time from impaired ovarian function, and what those commonly are due to are things like autoimmune diseases like Hashimoto's thyroiditis or genetic diseases like Fragile X syndrome. What is perimenopause? These are the years prior to your final menstrual period when you're experiencing menopausal symptoms, but still having periods. And this is a really important time because the way we manage your symptoms is different. This is also an important time to define because the symptoms that affect your quality of life start to show up this time period. So this is when women start to want to address menopausal symptoms. The symptoms in perimenopause, which is again before your final menstrual period, are different than the ones after. Before menopause, there's an abnormal axis between the brain and the ovaries, and that can actually cause the estrogen to be elevated before it goes down. So there's symptoms with elevated estrogen as well as with low estrogen. Symptoms from elevated estrogen can be things like breast pain, growth of uterine fibroids, also called leiomyoma, heavy or irregular periods. Migraines can worsen through this time, and a thickened uterine lining or polyps are also common. In regarding to the demographics of menopause, about 6,000 US women reach menopause every day, and that's over 2 million women per year. A woman's life expectancy is actually 80.5 years. So the way I look at it is that menopause is 3 decades of opportunity to improve the health and well-being of a woman. Menopause is certainly a health milestone. It's noteworthy to remark on. It's a signal of a new phase in a woman's life. It's the end of the female reproductive phase and the start of a new phase in their life as far as their health and well-being go and as well as their symptoms go. So it's an opportunity to reassess their health status and health goals. And we're getting to now the symptoms of menopause. This is a chart that's a little bit busy, but I'm going to draw your attention to a few things. This gray arrow is pointing to the final menstrual period. And again, you're not considered in menopause until you've had 12 months without periods. But what I want to make note of is that menopause is not a single event. It's typically 5 to 10 years of experiences that a woman goes through. For example, periods here tend to be irregular for about 4 to 5 years, sometimes longer and sometimes shorter, depending on the woman. And temperature sensitivity can be a problem for women for typically the first 2 years before menopause and 2 years after menopause are the worst. And notice that I didn't put hot flashes because temperature sensitivity includes all the temperature sensations that a woman might experience. And we'll go through that in just a minute. Finally, urinary and vaginal symptoms, and we'll talk about what those both are, happen after menopause typically. So after you've had 12 months without periods, women can start to experience urinary and vaginal symptoms. So certainly 5 to 10 years of a woman's life where they have significant symptoms. The time frame that you're in is very important in interpreting the symptoms you're having, as well as assessing the risk of any symptoms you might be having. If you're having bleeding in this time period, late menopause, 5 to 10 years after you've had your last period, versus if you're having irregular bleeding here, we interpret that very differently. So it's important that we figure out where on this timeline you are. As far as midlife changes that a woman experiences, irregular periods occur in about 90% of women. Most people will experience this prior to their final period. Every now and then I have a woman who told me one day they just stopped, and that's a lucky woman, but 9 out of 10 women will have irregular bleeding. Hot flashes occur in about 75% of women. Urinary urgency, which means you feel like the urge to go, and frequency, which means you go frequently, occur in about 50% of women, and this tends to be after your final menstrual period. Vaginal atrophy, which means thinning. We'll talk more about all these topics in detail here in a bit. Dryness and pain with sex occur in about 50% of women, and recurrent UTIs occur in about 20% of women. These 3 last bullet points occur after menopause, where these top 2 tend to occur before and immediately after your final period. Other midlife changes include weight gain or redistribution. It's about 5 pounds on average. And in regards to redistribution, what I mean by that is women tend to gain more weight in their midsection as opposed to hips or breasts, which is where the weight is distributed prior to menopause. And that's just due to the ratio of estrogen to testosterone. Your testosterone level doesn't go up, but your estrogen goes down. And so there's less balance there. And the testosterone hormone directs the weight gain to the belly. There's hair and skin changes that we'll talk about. And some women experience cognition changes, and that might include concentration, memory, or mood. In regards to all of these symptoms that we just mentioned, UTI is the only one that certainly warrants treatment. The rest of them may or may not warrant treatment. The first thing we're going to talk about is hot flashes. We said that about 75% of women experience this. The first thing we're going to talk about is that, which is not necessarily a hot flash, but a narrow thermoneutral zone. And what that means is the zone that your brain interprets as a comfortable temperature. The way I describe this to women is some thermostats have the capability of not turning on the air conditioner or not turning on the heat unless they're out of a certain zone. So for example, my thermostat is set 68 to 72, and the air conditioner doesn't go on and the heat doesn't go on unless it's outside of that zone. And it's the same thing in menopause, except that zone becomes very narrow. So your brain may interpret the temperature that you're in as uncomfortable where it didn't prior to menopause. So some people don't necessarily experience hot flashes, but rather experience extreme temperature sensitivity. A hot flash per se is a sudden sensation of heat that starts in the chest or the belly. And it's an extreme sensation, and it starts usually within 30 seconds and lasts about 1 to 5 minutes. It takes up to 30 minutes for your body to normalize temperature after that. And what that usually involves is the vessels towards your skin start to dilate to allow heat to release. And that causes heat loss, sweating, and chills. Now, some women are going to be a lot more sensitive to the heat loss and chills, so they experience these temperature changes or hot flashes as cold flashes, and they are all from the same etiology, so we can treat them similarly. So whether you have extreme temperature sensitivity, hot flashes, or cold flashes, they all come from the same thing generally, and they can be treated. They are typically most intense prior to your final period, the first 2 years before, and the first 2 years after. Like I said, some people are more sensitive to cold sensations and rather experience cold flashes. Things you can modify are alcohol consumption. Cigarette smoking narrows your thermoneutral zone significantly, so stopping smoking can help with these significantly. Hot drinks and spicy foods, and by spicy foods, what we mean are not necessarily not adding spices to your foods like dill and parsley and thyme. Those actually help with your thermoneutral zone, but spicy foods in the classic sense, like jalapenos and spicy Mexican food, for example. Stress can worsen hot flashes. The environment that you're in may need to be adjusted to your thermoneutral zone until we adjust that medically. And weight does affect your body's ability to maintain temperature. And so as you gain weight, which also is a common side effect of menopause, your hot flashes can also get worse. Irregular periods are also a common symptom that women go through. This is in perimenopause, and so before your final menstrual period. What happens is the periods typically become closer together. They can become heavier prior to your final period. I tell women these periods typically get worse before they get better. It's important to know that you can still get pregnant during this time period, and the risks of an unintended pregnancy in your 40s and early 50s are going to be higher than the risk of birth control. The rate of unintended pregnancy is actually highest in teenagers and then goes back up again in women in their 40s. And that's because women will frequently think that they don't need birth control anymore as periods get irregular. But I certainly see a lot of unintended pregnancies in their 40s and early 50s even. And so birth control is certainly warranted in this situation if safe for that particular woman. Medical history, not the age of a woman, determines if a woman can still be using contraceptives, and contraceptives are the same thing as birth control. So there's not an age that I say you absolutely must stop using hormones or birth control, but rather what we look at is all of her medical problems, what birth control she's using, what her goals are, and we determine if that's reasonable for her to continue or not. The next thing we're going to talk about is bleeding after you go through menopause. So after a woman experiences menopause, which again is 12 months without periods, any bleeding should be investigated by a doctor. The most common cause is actually vaginal atrophy, which is thinning of the vagina, and which is not a dangerous medical diagnosis. However, there are more concerning causes like endometrial cancer, which is cancer of the lining of the uterus, and that should be ruled out in any woman who's having postmenopausal bleeding. Vaginal atrophy is the next topic we're going to discuss. Symptoms such as vaginal dryness, irritation, itching, and painful intercourse are all common. And unlike vasomotor symptoms, and vasomotor symptoms is a title that we use to describe all the temperature sensation changes that women experience. So unlike those temperature sensation differences, which decrease over time, usually about 2 years after your final period, vaginal atrophy usually gets worse and is progressive, and it's unlikely to resolve on its own. It usually continues to progress over time. The ways we can treat this are with specific types of lubricants, vaginal moisturizers, local vaginal estrogen, and regular sexual activity actually helps the vagina respond and maintain its elasticity. So some people will say if you don't use it, you lose it, and that's certainly true in the case of vaginal atrophy. This is just a picture to help you understand what we're seeing from a medical sense. What happens with vaginal atrophy is that the tissue in the vagina, as well as the urethra and the bladder, all change in the presence of low estrogen. And the reason that is that when we developed as babies, the tissue that forms the end of our urethra, as well as the bladder and the vagina, all comes from the same type of tissue. Therefore, they all respond to estrogen the same. If you look in the figure on the left, you see that the tissue is wrinkled. There's 2 thick layers. On the figure on the right, the wrinkling is not there and the layers are very thin. And this is a low estrogen, or this is a high estrogen state before menopause, and this is a low estrogen state after menopause. The collagen types in the tissue actually change, which affects the stretch of the tissue. With intercourse, some women experience pain just from deep penetration because there's not a significant stretch of the tissue, and they're much more likely to have tears in the vagina because of that. There's also less natural lubricant when there is vaginal atrophy, and the tissue is less plump. It's not as thick. And the reason I say that specifically is because of how the urethra is affected by menopause. And this is just a picture here. Urethral and bladder changes cause urgency, feeling like you need to go all the time, or feeling like once you get to the bathroom, you can't hold it. Incontinence and recurrent UTIs. Now, not every recurrent UTI in a postmenopausal woman is going to be from menopause itself, but certainly many symptoms we can control just by replacing some estrogen, and that might just be with a cream. These are 2 examples of what I see frequently when I'm doing exams on postmenopausal patients. What this is a caruncle, and what this is that the urethra has essentially everted or prolapsed out, and this is the inside of the urethra, which should be tucked up inside, and it's kind of prolapsed out. And that can certainly cause symptoms like urgency or incontinence. But most common symptom with a caruncle is urgency. And you can see that this urethra has completely prolapsed out. I don't commonly see these, but I do commonly see urethras that have undergone atrophy. And what happens when the urethra undergoes atrophy is that it's not as thick, so it's more likely to be open. And when it's more likely to be open, bacteria can travel backwards, and that's how we end up with recurrent UTIs in postmenopausal patients. Prolapse risk also increases in menopause, which can affect urinary symptoms as well. And of course, like I said, we don't blame every urinary symptom on menopause. So if you're having significant symptoms, we should address all the possible causes, as well as potentially treat the menopausal side of your urinary symptoms. In regards to weight, this is a really common question I get. Many women gain an average of about 5 pounds at midlife, related mostly to aging and lifestyle, but not really menopause or hormone therapy. The weight redistribution is the most common thing that we can reliably kind of blame on hormones. And what I mean by that is that the ratio of estrogen to testosterone or androgens changes, and so where your body knows to put the weight is different. So the weight goes to the belly rather than the breasts and the hips. Menopause, like I mentioned, certainly can be related to changes in body composition and fat distribution, and it's much more difficult to lose the central fat. The other thing that I talk to women about, and this is especially when we're trying to decide if hormone replacement is right for them or not, is that sleep deprivation is absolutely linked to weight gain. And when a woman is sleep deprived, she's much less likely to exercise. So hormone replacement therapy doesn't necessarily cause weight gain or help you lose weight, but it absolutely helps with hot flashes and sleep deprivation, which helps with weight loss. The skin changes that women experience are typically due to the drop in estrogen. There's a really high concentration of estrogen receptors in the skin. And when there's a decline in estrogen, that's highly correlated to the decline in collagen and the skin thickness. And so what happens is the skin is more lax, and that results in wrinkling. It's the similar kind of topic as the vaginal atrophy and how the collagen changes in the vagina as well. There's a 30% decline in collagen within the first 5 years of menopause, and then it's about 2 years yearly after that. So most women notice the most significant change right after their final menstrual period. There can also be increased tender acne, and what that means is the acne that doesn't necessarily, most people wouldn't call it a whitehead or a blackhead. It's the redness that is really sore, and that's due to the elevated testosterone estrogen ratio. And women get really upset by that. They feel like, goodness, haven't I already put in my time? But that's something that generally will go away. What hormone therapy can do for skin changes is it might decrease the wrinkle depth and pore size. It can help improve elasticity and firmness and increase moisture. It can help change that collagen type and limit the loss of that collagen and maintain the skin thickness. However, because of the risks of hormone therapy, we should never be using it for your skin alone. We should be using it for other things. And one of the benefits is that it might help your skin. In regards to hair changes, hair loss and excessive hair growth are common during menopause. And there's multiple contributing factors, including genetics, hormone changes, and stress. There is female pattern hair loss in some women, and that's typically a gradual thinning occurring mainly on the crown of the scalp. And it starts in many women as the widening of the part of their hair. There can also be sudden onset hair shedding. The medical name for that is telogen effluvium, and that's when you're losing patches of hair. And what most women will experience is just rogue hairs around the chin in menopause, again, from that change in the hormone ratio. The next topic is how we treat the symptoms of menopause. So the first thing I want to know is if the symptoms that a woman is experiencing are significantly affecting her life or well-being. So hormone replacement is not used for all women in menopause. There's a few scenarios where we would always use hormone replacement. And that's if, for example, if I had a 21-year-old where I removed her ovaries, she needs hormones for the health of her bones and her cardiac well-being. So she would almost always go on hormone replacement. But not all women who go through menopause need to be on replacement. It's not used unless you have specific symptoms that hormone therapy is approved to treat. And the route that you take the hormones, whether that's a cream, a patch, a pill, or a ring, matters in regard to how well it will work for your specific symptoms and the risks associated with that hormone replacement. When we're deciding what's right for a woman, the questions we ask are, have you had greater than 12 months without periods? If a woman is still having periods and is sexually active, pregnancy prevention and period concerns are taken into consideration. Another big important question we ask are what your other medical conditions are. So common ones that would change what we might choose are blood pressure, history of clots, and your weight. Other questions we ask are what are your symptoms and what is your age? Because when we start hormone replacement therapy, changes the risks associated with it significantly. And the other question I ask is what is your ability to use the recommended medication? So for example, positioning might be difficult for a woman who has significant arthritis in her hips to place vaginal estrogen or cream. For women still having periods, there are many different approaches. And what you're going to see kind of listed here are what people classically think of as contraception or birth control: implants, patch, pills, ring, the IUD. A birth control pill actually has higher doses of the same hormones that are commonly used in hormone replacement therapy. So I frequently will have a 49 or 50-year-old woman coming to me who's still having regular periods on a birth control pill wanting to go on hormone replacement therapy. And to that woman, I would say first thing we need to figure out is if you're in menopause. And usually what that involves is stopping her birth control pill, checking labs to see if she's in menopause, and then deciding is hormone replacement therapy most reasonable or continuing the birth control pill. Sometimes when we switch a woman from a birth control pill to hormone replacement therapy, they may have worsening of their symptoms. And that's because the higher dose of hormones in the birth control pill and going to a lower dose in hormone replacement therapy, they might not have as good control of hot flashes, for example. In women who are postmenopausal, typically the hormone replacement that we use is via a cream, a patch, a pill, or a ring. Common risks with estrogen include blood clot, heart attack, and stroke, but the time that you start therapy is significant to how that risk might affect you. We do not believe estrogen alone increases the risk of breast cancer. So I have many women who've been dealing with debilitating menopausal symptoms, but have not sought out care with an OBGYN because they think that all hormones increase the risk of breast cancer. And recent studies suggest that that's not necessarily the case. Risks with progesterone include, but are not limited to, breast cancer. We think that taking both estrogen and progesterone together doesn't actually increase the risk of breast cancer out until 3 to 5 years of use. And so for women with a family history of breast cancer, which given the rate of breast cancer of 1 in 8 women, most people have a family history. Hormone replacement therapy is not necessarily something that we should avoid in those women, especially since it doesn't increase breast cancer risk until several years of use. We may need to use both hormones, both estrogen and progesterone, or we may be able to use estrogen only. And the reason for that is we think about the health of the inside of the uterus when we're choosing which hormones we use. Estrogen causes thickening of the lining of the uterus, whereas progesterone causes thinning. So if we were to give someone who's after menopause estrogen only and she hasn't had a hysterectomy, the lining of the uterus could get thicker over time and increase the risk of endometrial cancer. So to protect the uterus for women who have not had a hysterectomy, they need both hormones, whereas women who have had a hysterectomy may need estrogen only. And that avoids the increased risk of breast cancer with progesterone. I'm sorry, 1 second here. Can you help me get this top down? I can't read the top of my slides. So what are the treatment options? And that depends on the symptoms we're targeting to treat. There's non-hormonal medications and over-the-counter treatment options available as well. Excuse us for a moment. So first, I want to thank you. I know taking time to invest in learning about your health is something that not very many women do, but when you do, it has a huge impact on your well-being, and that has a huge impact on your family's well-being. We've talked a lot today about the negative symptoms about growing older, but I want to remind you that do not regret doing that. It's a privilege denied to many. And I hope I've empowered you to talk to your OBGYN or your primary care doctor about symptoms if they're affecting your life. My areas of interest include teenagers and contraception, minimally invasive hysterectomy, pregnancy, labor and delivery, mental health during reproductive transitions, and that includes postpartum depression, as well as mood changes in menopause, sexual wellness, and more. So I'm happy to see you or any of your family members for any of these topics. The phone number to our clinic is listed here, and I know we'll be working on getting my information out to anyone who's on the Lunch and Learn today as well. And I think we'll accept questions now.
Great. Thank you, Dr. Werner. A lot of good information there. We have a woman who has sent a question in, and she's 50 and she still has periods. Can you talk more about the age factor in regards to starting hormone replacement therapy?
That's a really good question. So I have a lot of women in my clinic who are aged 50 to 54 that are still having periods. And that's certainly reasonable. There is not necessarily an age in the fifth decade of a woman's life where I'm nervous about her still having periods. But what I would say is that if a woman is still having periods, we don't necessarily start hormone replacement therapy per se, but we can start things like a birth control pill. We typically stop birth control pills in all women around age 55, but they can be considered ages 50 to 55. And that would be a form of hormone replacement therapy that would be giving you hormones that are probably starting to decline and maybe helping some of the symptoms you may be having. But that does depend on the main concerns that this particular woman has. If it's hot flashes, the way we administer hormones might be different. Or if it's vaginal dryness, the way we administer hormones could be different. On the same kind of topic, a lot of women feel like, goodness, haven't I put in my time? Can I be done with periods? And there are certain types of birth control as well as surgeries that we can do to stop periods altogether.
And she was wanting to know, does hormone replacement therapy help with perimenopause? I'm sorry, I was on mute. She also wants to know, does hormone replacement therapy help with perimenopause migraines?
That's a good question. So there's the first thing to do if a woman is having migraines in the perimenopausal or menopausal period is we would sit down and have a visit that usually takes somewhere between 15 and 30 minutes and go through specific symptoms that they're having with their migraines to figure out if these are related to estrogen or not. Estrogen-associated migraines can certainly be improved by hormone replacement therapy. However, there are certain types of headaches that can worsen with hormone replacement therapy, and that depends on whether you're going to be using estrogen and progesterone together or estrogen only. And so that's a complicated question that certainly has a different answer depending on the type of migraine that her symptoms fit, as well as what hormone replacement therapy we might use. But in general, the answer to that would be yes, it could help.
Are there any natural treatments for postmenopausal women that can help with hot flashes?
That's a really good question. Simple ones that are behavioral. The first thing that I tell people is that exercising widens the thermoneutral zone in the brain. So being active, exercising, and maintaining a healthy body weight are things that will significantly help maintain a normal thermoneutral zone. So those can make a big difference. Second is what you eat. Even if it's a healthy diet, we kind of listed some of the common triggers to hot flashes. I have some women who, if they smoke or if they drink alcohol, even a glass of wine with dinner the night before, or if they eat spicy foods, that's the day that their hot flashes are really bad. So those things can make a big difference. And then there are several kind of over-the-counter or natural herbal remedies that you can try. Black cohosh is a common one that you could consider. The hard thing about these is that they're not FDA regulated. And some of these, the reason they help is that they can have they can play a role in how your body processes or sees estrogen. And so we just want to make sure you're not taking a large volume of estrogen without progesterone, thus increasing your risk for endometrial cancer. So we would sit down and visit if there were specific natural herbal remedies you were interested in. In general, depending on the symptom, such as hot flashes, we would talk about things that are going to work the best for that. There are also non-hormonal treatments for hot flashes. So things like gabapentin, clonidine, SSRIs are all really good treatments for that. And we use those commonly in women with a history of breast cancer, for example. So there's lots of different options that we can explore. And it's kind of a trial and error thing. It's not a science once we're to that point, it's an art. And so we would work with the woman in figuring out which option's best for her and then try and see if it works.
Okay. This non-hormonal is really striking for a lot of women here. The next question that's coming in, what would you recommend for dealing specifically with hot flashes so someone can stay asleep?
That's a really good question. So there's a couple things we think about. So if a woman is having trouble staying asleep, she falls asleep just fine, but wakes up because of the hot flashes. There are two different types of melatonin. One is immediate release, one's extended release. And sometimes an extended release melatonin, which is a natural hormone that's in your body, can be helpful for that situation. The other thing that we that I tell people to try is different pajamas. Watch what you're wearing to bed. Watch the sheets that you're using, not wash them. And sometimes having a fan in the room can be helpful. And those are all really simple changes. But if hot flashes are keeping a woman awake at night, the thing that's going to treat that best is honestly hormone replacement therapy. And the risks, depending on the age of that woman, may be certainly worth it, because if you're not getting good sleep, that affects your activity, your exercise, your mood. And I would say all of those things have more of an effect on your life than the risks of hormone replacement therapy. So that would be a perfect woman to consider starting.
Is HRT, hormone replacement therapy, covered by most insurances?
That's a good question. It absolutely is. So when I write my note, I always include how it's affecting a woman's life, and the way I word my note will allow it to be covered by insurance. So I've never had it not covered by insurance. Now that that's said, there are some medications that are going to be more expensive than others, just like any area of medicine. So things that are typically more expensive are like vaginal estrogen creams. But I have kind of little tips and tricks of the trade to get that cheaper, whether that be using a copay card, or I have several different coupons, or there's ways online to get it cheaper. And sometimes we'll trial several different ones to see what's cheapest for that specific woman's insurance.
So a question came in, will I still need an annual well woman exam? And if so, why?
That's a really good question. I answered that twice this morning for two different women. So if a woman still has ovaries and a uterus, she needs an annual well woman exam. Even if you're not getting pap smears every year, we are assessing your breast health, your colon health, your vaginal health, your sexual well-being, and any concerns you might be having with vaginal bleeding. It's important that you do get a yearly pelvic exam by an OBGYN, because the only way to screen for ovarian cancer is a pelvic exam. And so you want that exam to be done by someone who feels ovaries every single day. And so I would say it is worth going to an OBGYN once a year still, even in menopause.
And what online resources do you recommend for solid information about menopause?
That's a good question. What I typically use is the North American Menopause Society. And that's a large group of OBGYNs that specifically focus on menopause. It's a society that I'm a part of, and they do lots of interesting talks. You could actually go on there now and follow some of their talks on things like migraines, skin changes, etc., in more detail, because we kind of did a wide overview today. But the North American Menopause Society has a tab specifically for patients that I like to use.
Great. We have our last question here. You've given us so much great information. As you drill it down, what would your 3 top pieces of advice be to women experiencing menopause?
One is to not grin and bear it. If you're experiencing symptoms that are affecting your life, it's worth treating and worth at least visiting with your provider about. So one, I think your lifestyle and your well-being are important enough that these symptoms should be addressed. And that includes if it's just affecting your sexual health. A lot of women think that, oh, well, it's just part of it. But the sexual well-being affects our overall well-being. So any symptom that's affecting your life is worth addressing. So that's number one. Number two is that, contrary to popular belief, we don't always follow hormone labs. What we typically treat is symptoms. So checking labs and treating labs are not what we do. We treat people. And so a lot of women want me to just draw their labs and look at those values. And menopause is far more complicated than that. We have to look at all the symptoms a woman is having. And so what I encourage people is to think about menopause as treating the woman rather than treating labs. And third is hormone replacement therapy is safe for many women. There's risks with every medication a woman chooses to start, and there are risks with hormone replacement therapy. But for the right woman, it can certainly improve her quality of life. And if used for the right duration of time and the right hormones, it can be relatively safe. And choosing whether that's right for you with your doctor. If you both choose that that's safe, I think that's certainly a reasonable option. And it doesn't mean you'll use it forever. Some women need it for 1 or 2 years. Other people need it for 6 or 7. And so I think that hormone replacement therapy is a really great kind of way to treat some of these symptoms, but is not for all women.
Thank you, Dr. Werner, and thank you for joining us. We hope you have the information you heard today will help you manage your menopause symptoms as you move through this phase of life. If you would like to learn more about Dr. Werner's approach to women's health, visit meritushealth.com/JWERNER and consider joining Club W at clubwkc.com. Have a great weekend.